gets to use those services without having to pay for that research cost. Plus, the governments are the ones that buy the services. After World War II in Europe, the governments had to put things together very quickly. They were the only ones that had any ability to build anything. They borrowed money from all the other countries, and we came in and helped rebuild a big part of the European market. But they put in nationalistic and socialistic healthcare systems almost immediately. And if you remember, maybe you do, prior to World War II, there were a lot of working groups, union working groups in Europe, and they continued to move very aggressively. And because of that, they pretty much covered everybody for everything, and that was their way of getting the country healed, getting it back on track. But it was never intended to do that forever, but once you put something in place like that, it's tough to pull it apart. Okay? If you take a look at the Middle East, these are emerging markets. The emerging markets are looking at healthcare in Europe, they're looking at healthcare in the United States, and they're going to approach it totally different. They don't like the European system because they don't want to get caught in what's happened there. They don't like our system. So what they're going to do is they're going to build the hospitals, they're going to provide the diagnostic capabilities, but they're going to let the private sector run everything. So it'll be interesting to see how that all turns out. They have the advantage, they haven't got the aging population. But the other challenge they have is they've got a demographic that is made up of all these expatriates from all over the world. If you go to France, if you go to, except for Germany, you go to England, a significant percentage of the population is not English. I mean, France is not French. And definitely in Saudi Arabia and the United Emirates, they're from all over the place. Sri Lanka, Indonesia, Yemen, Chechnya, the Ukraine. So they had to create a different kind of system. England, US, and Canada. I've got a sheet here. I will not read through it, but it gives you some comparison in terms of their system and survival rates for certain things. For example, I'll just talk about cancer. Men and women who survive cancer 5 years after diagnosis in the US, 65%, in England 46%, and in Canada 42%. And again, I will send this to you if you'd like to have it. It talks about a variety of other things. So why the healthcare system seeks reform? So 40% of the population receives entitlements. 6% in 10 years based upon, if you take those 40, 50 million people who are uninsured, underinsured, not want to be insured, and wrap them into the program. If you go to a hospital today and you ask them where they get their revenue, 60% of the revenue is coming from Medicare. 10% is coming from Medicaid, and 30% is coming from the private sector. So who really is the largest payer of health care benefits in the United States today? The government, all right? They already are. We're only talking about 30% that isn't. So this is not very far to go, all right? And the challenge is hospitals know that they only get about a 1.5% increase in Medicare inflation rates, with a hospital running 8% in terminal care inflation. And Medicaid pays about 30% of what Medicare pays. And the new programs and the new insureds are going to be covered under what program? Medicaid, not Medicare. And remember, in Medicaid, the state pays 50-50, right? So another new unfunded mandate to the states, and there's only one way to pay for that: taxes. There's only one way to pay for that, okay? When you look at the population demographics, 20% of the people use 80% of the benefits. If you look at an individual in their lifetime, and you look at your lifetime as $1 healthcare services, you're going to use 80 cents of that $1 after you turn 65. And you're going to use 90% of that 80 cents in the last 6 months of your life. Okay? This does not happen in Europe at all. Okay? They do modify the way in which benefits are provided in Europe. They don't call it rationing, but if you go to England today, if you want to get health care past 65, or health care in some cases at all, you have to buy private health insurance because the government's cut back that much. Okay. fewer primary care physicians and more specialists, increase in uncompensated care, too many new hospital beds. I talked about younger people seeking alternative care. Technology is not driving down costs. We're actually seeing more people utilize services. For the first time, 5 years ago, there were more women in medical school than men. The companies of Walgreens, Walmart, Rite Aid, CVS are building mini clinics all over the United States. And they're going to be hiring nurse practitioners and physician assistants. There's already discussion and there's legislation being pursued that will allow pharmacists to prescribe. If you haven't been in a state where they have a mini clinic, you walk in, you see a nurse practitioner, it's $30, and if you're in Walgreens, they give you a coupon to buy something in there and give you $5 off. And for people who are under 30, and remember, half the population is under 30, this is a great deal. They're not loyal to anybody, they're not loyal to a product, loyal to a doctor, so that's what they're going to use. And from their perspective, it's a great system. It cost me $30, right? Quality is a definable delivery site and often a smoke screen to perform more services. Quality is one of those terms that, you know, if we have to cut costs, we reduce quality. When I did my master's thesis, I did a survey on why people choose certain providers, certain pharmacies, but I also asked the question, how do you decide what quality is? Top 3 that came back. Number 1, when I called, I got an appointment and I was able to get in within 2 days. Number 2, when I got there, the receptionist smiled at me. And number 3, when I saw the doctor, his lab coat was clean. Top 3 indicators of quality. Had nothing to do with outcomes. Okay? Lack of tort reform. The current legislation has no tort reform in it. I have a brother-in-law who's an attorney, and I have another brother-in-law who's a doctor. And we went and played golf a week and a half ago. And you can imagine the interesting conversation we had. We tried to stay away from this subject as much as possible. And they're both opposite of what I am politically. So it was I made sure that I stayed behind them when they were hitting the golf ball. Okay. Cost of competing in the world we've done in services. We've got hospitals of 300 beds building linear accelerators. Very expensive, and there's down the road there's another linear accelerator, and another linear accelerator, or level 3 NICUs all over the place. They all want to go after the same service. Nobody's willing to say, I'm willing to give this up and just take this particular service. So the competition is driving up the price of healthcare even faster. If you go and talk to a chief financial officer of any hospital, he will tell you today, or she will tell you, that their goal is to get 42% of charges. Now, he talked about costs. There are no costs in healthcare. Healthcare is not a cost-based industry. Healthcare is a charge-based industry in a cost-based economy. And that's why it can't get into mesh. When you go to the physician's office, do you ask them how much something costs? No. What are you charging? Okay? If you go to a physician's office, and Dr. Zani can tell you, he'll have 42 different compendiums, because for that particular service, there's 42 different rates he gets reimbursed depending on the insurance company. There's no standard, right? So the industry's got to look at also changing where it's delivering services. Communities of your size, with a cold water hospital, it's going to change. Right now, there's 4 big companies out there buying up those hospitals like crazy. CHI out of Chicago, Catholic Health Initiatives, Adventist out of California, Tenet out of Tennessee, and HCA out of Tennessee. And there's a few others, but they're buying them up like crazy. They're taking them, stripping out the ED, turning them into clinics, creating a tertiary care relationship, and they're getting ready to build the ACOs. I haven't got time to go over the ACOs, but the ACOs, the accountable care organizations, is what's going to be built. That's going to be part of the exchange system. And for those of you who understand how DRG works, that's what's going to happen with the ACO, except it's going to expand across all levels of services with one reimbursement. Not unlike most companies, costs for running a hospital, 70% staff, 20% supplies, 10% building and grounds.